When you diagnose MS, who's the first doctor you go to? Well, I can tell you from my experience in the last few years, the first doctor you go to is Dr. Google. You know Dr. Google? Yeah. So most people who come to our clinics now come with, they usually arrive in the consultation room with an idea they have MS. It's very unusual now to get people who don't have an idea. And so the idea of having somebody there in your room who hasn't Googled their symptoms or worked out what they've got is unusual. And so that's the era we're in now, is people actually come with a diagnosis. And so that makes it very, very difficult, because most people usually have an idea. And I would suspect if you're in Scotland, your threshold for thinking you've got MS is much higher than elsewhere in the world, simply because of the incidence. I mean, I just was looking at the figures. The prevalence in the Western Isles is exceptionally high. The figure I've just worked out using the denominator of 26,000 people was over 300,000. It's 334, 400,000. That would make it the highest prevalence in the world. So we always thought Orkney and Shetland were high. They were around, previous figures were about 280 per 100,000 people. So over 300,000 people would say this would be the highest prevalence area in the world. It's not a competition. It just means that this part of the world has more MS than most other parts of the world. There's one little area in Canada that competes with you. It's the central part of Canada, Saskatchewan. Well, I was recently there, and that's also in the same region. Rachel's figures would suggest that the incidence in this part of the world is around about 15 to 16 people per 100,000 per year. That's the incidence. So you've got to realize that you're in an area of the world where there's something happening that makes this disease extremely common. I wish we knew. So I'm going to talk to you about the diagnosis of MS and its pitfalls and mimics. I'm told I've got 10 minutes. I've got far too many slides. Just to say to you that we as neurologists diagnose this disease using criteria. We can't actually do brain biopsies. That's the way we should diagnose this condition. We can't do that on everybody. So we have to rely on filling these criteria, and the criteria change every 4 or 5 years. We're now on to our 6th rendition of the criteria. The first ones came out back in the mid-60s, and then it was 2 clinical attacks, and we have to exclude other conditions. And then we went into the 80s, and we included things like spinal fluid analysis and electrical tests. And then we went into 2000s, and we included MRI scans. And essentially, we have to have a disease that disseminates in time and space. Time being 2 attacks at least a month apart, and space meaning different parts of the nervous system, so like the eye or the spinal cord, for example. And what's happened over the last 20 years is we've actually refined the criteria. And that the refining of the criteria is essentially moving the diagnosis much, much earlier. And so now we can actually make the diagnosis using usually 1 attack, and we have to include the spinal fluid analysis. And if there's abnormal oligoclonal bands, these immunoglobulin bands in the spinal fluid, that tells us the disease has been there a long time, and we can say dissemination in time. That helps because by being able to tell somebody's got MS, we can actually potentially initiate treatments, depending where you are, earlier. And I think that's important because it's overwhelming now that the earlier we begin the treatments, the better they are. What we can't do is diagnose the condition in the asymptomatic phase. In other words, before people have any symptoms. And that, to me, is a little bit of a problem, because if we want to make a big difference to this disease, we would like to pick it up as early as possible, even before people have symptoms. If you want to know how good we are diagnosing this disease, there's a thing called the sensitivity and specificity of criteria. How many false positives are there? So how many people are diagnosed with MS and don't have the disease? And how many people are we missing because they don't fulfill the criteria? And that's what the sensitivity is. And so this is actually the best data we have. So this is a study done in Denmark. Previously in Denmark, everybody who died had a post-mortem. So when somebody dies with a post-mortem, you look at their brains, you can say who's got MS and who was diagnosed in life. And so this Engel paper that's way back in the 80s is based on a post-mortem series of over 5,000 people. And he was very interested in MS, and he looked at all the brains. And very, very interesting, in the post-mortem series he had, there was just over 500 patients that were diagnosed in life, and then they died, and he looked at their brains. And the false positive rate was 6%. So in other words, about 1 in 20 people who were diagnosed in life with MS at post-mortem didn't have the disease. And you look horrified. That's not that bad, because if you look at diseases like Alzheimer's, it's even worse than that. Alzheimer's disease is about 20%. 1 in 5 people who get diagnosed with Alzheimer's in life, and they come to post-mortem, they have another disease. And Parkinson's disease is even worse. It's about 1 in 4 diagnosed with Parkinson's. When they come to post-mortem, they don't have Parkinson's disease. But anyway, so Rachel, about 1 in 20 your patients don't have MS based on these figures. They have another disease. So this is why it's difficult, because our criteria that we use to diagnose this condition are not that great. They're okay, but we've always got to remind ourselves that anybody who has MS could always be misdiagnosed, and we need to always keep thinking about what else could they have. Now, what about the other way around? How many people are missed? And so in the same study, when he's looking at all these brains, he estimated that about 25% of people, that's a lot, never get diagnosed. So 25% of people who die, and in their brains they have MS, were never diagnosed in life. So that either means that they were never symptomatic, they never had symptoms, or if they did have symptoms, the symptoms were very mild, and they were never brought to the attention of a doctor or a neurologist. So there is quite a large number of people in the community who have MS, but they've never brought their symptoms. So you need to think about, non-specific symptoms or symptoms that are suggestive of MS often get ignored. And this is one of the biggest problems we find with when people come to us and we diagnose them, we go back into the histories, they've had symptoms for years, sometimes decades, that have been ignored or put aside to various different complaints. Trapped nerves, stress, etc. So I think if you want to make the diagnosis earlier, I think people with relatively non-specific symptoms should be referred into the system so that they can be assessed for MS. Anybody know about Will Rogers? So Will Rogers is if you're in America, you'll know about Will Rogers. He's a comedian he lived in Hollywood. And he's very, very kind of in the silent movie era. This is when movies were made without voice. But he made this statement when the Okies from Oklahoma, this is in the Great Depression when people migrated because of no work, and they went to California, which is the Golden State. When the Okies left Oklahoma and moved to California, they raised the average intelligence levels in both states. So it's like when people leave the mainland and come to the Western Isles, the intelligence levels of the mainland will go up as well as in the Western Isles, okay? And so it's actually become, this statement is actually correct, and it's now become known in statistical circles as the Will Rogers phenomenon. And I'll explain to you what it means. So we did this, so this is actually changing of the diagnostic criteria for one of the types of MS called primary progressive. So primary progressive is about 10% of the population. They don't come with an attack, they come with gradual worsening of their symptoms, and maybe a walking problem. And so it's about 1 in 10 people will be diagnosed with primary progressive MS. And so when the criteria came out back in 2001, you had to have an abnormal spinal fluid. And the Americans didn't like this, because the Americans don't like doing lumbar punctures for legal reasons, etc. So they lobbied the committee, and the committee decided, let's not make the CSF the spinal fluid analysis essential. So they made it a criteria that was not necessarily part of the main criteria, so they shifted it. And so what happened was when we did a clinical trial, and this is one of the drugs we use, it's called Copaxone. It was tried in primary progressive MS. And when we actually analyzed the results of people who had a lumbar puncture and were abnormal, these two populations behaved differently. So those who had a negative spinal fluid did a lot better in the trial than expected. So the trial was negative. So this is why it's very important, we think, to do a lumbar puncture in people with primary progressive MS. And so what actually happened in this trial is we think that a lot of people who had negative spinal fluid analysis probably didn't have MS. And they were shifted from the group that didn't have MS into the group that had MS. And so this is what happens when we change diagnostic criteria. This is what happens when we change. So you can actually see there in the top there, non-MS, CSF negative, goes across, becomes a part of the criteria. The prognosis in the two groups improves. This is called the Will Rogers phenomenon. I'll put this in here because when we did the clinical trials, we learned from that. And most of us who are involved in doing trials in people with this particular type of disease now make it essential that the spinal fluid analysis is done. So the definition evolves, and some of us go backwards and apply the retrospective criteria. Now this study comes from Barcelona. Now this is not looking at the primary progressive. This is looking at the people with relapse onset, attack onset disease. So these are people who present with their optic neuritis, loss of vision, or their sensory, etc. And when you classify these people using old criteria, which is the Poser ones, those are from 1980, versus the McDonald, which is the new criteria in 2000, you can see that the prognosis there of both groups, CIS means the first clinical attack, and MS means you have your second attack, improves. So this is actually a real phenomenon. And so what's happening in the Western Isles is people getting diagnosed now will have a better prognosis than people were diagnosed 30 years ago, simply because we've changed our criteria to diagnose the condition much earlier. And so this is an observation about the Will Rogers phenomenon. Now, the differential diagnosis, one of the criteria is we've got to have this condition that disseminates in time and space, and we have to exclude other things. And I wanted to give you an example of a patient. We as neurologists always have these things called flags, things we look for that actually indicate another disease. And I will refer you to this particular paper, which we can circulate to everybody who wants to read the paper about the number of flags. And the list is very long. You see that list there? Each condition mimics MS. And so that's one of our jobs when we get people referred to us, is to take a history, examine them, and do tests to make sure they don't have a disease or another condition that mimics MS. And so these are the commonest ones. It could be tumors, it could be an infection. Often, these are the mistakes I've made in my life. You get people who are coming with walking difficulties, and they have a disc, a thoracic disc, for example. This is a case of an example that I think may be relevant to the Western Isles, of a patient who was referred to me. So this was a 34-year-old man. He developed tingling in his toes. He was found to be anemic, and that's a flag. You know, people with MS shouldn't have anemia. And his anemia looked like he had a hemoglobin of 11, which is relatively, it's not that bad. Most people with anemia are below 10. His vitamin B12 and folate levels were normal, and his symptoms gradually progressed. And he was referred to a neurosurgeon because of his symptoms by the general practitioner, and his MRI was abnormal. But the neurosurgeon worried that he had MS, so he was referred to a neurologist. His scan did show this a long lesion in his spinal cord, and so this is why it was considered to be MS. Now, that's not a typical lesion in MS. So for the neurologists in the audience, they'd look at that and they'd say, well, it looks like a condition called subacute combined degeneration, which is due to vitamin B12 deficiency. Here's another. And so he was put on vitamin B12. His levels were normal though, and he had no improvement. He was then referred to hematologist because of the anemia, and they actually did a biopsy of his bone marrow, and his bone marrow came back as being dysplastic. It wasn't very specific, but it was abnormal. And they did electrical tests of the eyes, and it showed slow conduction, which is a marker of demyelination, abnormal myelin. And so he was considered to have MS. Anyway, when I saw him, he had abnormal visual acuity. His color visions were not normal, and at the back of the eye, his discs were pale, which would indicate that he had lost some nerve fibers. And he had this pattern of loss of feeling that was compatible with an abnormal nerve function, a neuropathy. Anyway, this is the kind of investigations we did on this patient. We did extensive investigations from him, and the important thing here is his spinal fluid analysis was normal, and that makes it very unlikely that he had MS. And his electrical tests suggested demyelination, and all these other tests were essentially normal. We couldn't pin down why he didn't have MS, because he'd been diagnosed by his previous neurologist as having probable MS. So this is what I would call the phenotype, the clinical picture. He had abnormal visual function. He had abnormal spinal cord function because he had weakness in his legs. He had an abnormal nerve function. And he had this bone marrow problem. And when we actually did the detailed test, it was quite clear that his iron metabolism was abnormal. Iron was trapped in his nerves. So the neurologists know this, what this condition is. Anyway, the bottom line is that when we actually tested this gentleman, he had abnormal zinc metabolism. He had very high levels of zinc. Okay? And his copper levels were very, very low. And so he's got a condition called, he's got a spinal cord condition due to very, very low copper levels. And the reason why I put this case in, because he's got a condition that's, in the Western Isles, in Orkney and Shetland, the sheep get this condition. So I don't know if the sheep in these parts of the world actually eat a lot of seaweed. And the seaweed is very high in copper levels. And so if you eat seaweed, you then get copper toxicity. So the sheep have acquired a mutation in their absorption of copper to protect them. And when you take these sheep off the islands, and you put them on, you get them eat grass, they actually get copper deficiency, and they've got this condition called swayback. They get unsteady on their feet. So the vets call this swayback disease. So this gentleman has got swayback, human disease, and it's mimicking a multiple sclerosis. And the reason is, why has he got copper deficiency? And the clue there is zinc. He's getting too much zinc in his diet, so he's obviously eating the zinc, or he's getting it given to him in some way. And we know that copper deficiency now is not common, but it's a very, very rare manifestation of MS, a mimic of MS. Anyway, I had this opportunity. What you do in academia, you get asked to review articles for journals. It's called peer review. And at the same time I saw this patient, my colleague in London, Professor David Miller, asked me to review this particular case of a woman who had a gastrectomy. She had a peptic ulcer. You don't do gastrectomies anymore for peptic ulcer, because peptic ulcer disease now is due to an infection, so we treat it with antibiotics. But before we had, people used to do surgery for it, and so they took out she had a gastrectomy, and that's one of the causes of copper deficiency. And so I wrote an editorial describing her condition as human swayback disease, because the manifestations in the human is very similar to what happens in sheep when you move them from the islands to the mainland. And so this gentleman had swayback disease. Now the reason why he had it, it took us a long, long time to work out how this gentleman was getting zinc toxicity. And the interesting thing is he was addicted to Coca-Cola. And he lost all his teeth at the age of 17 from drinking Coca-Cola. And he was drinking about 14 plus cans of Coke a day. He didn't drink any liquids apart from Coca-Cola. So from the time he woke up in the morning until he went to bed at night, he used to just have a can of Coke. And obviously the sugar had destroyed his teeth. And he had dentures, and he was sticking his dentures in with a thing called dental glue, you know, and that had a lot of zinc in. And he was the index case now across the world. All the people that have got this condition from their denture paste are suing the company GSK for causing their condition. Okay. But anyway, it's well known that zinc toxicity, which probably is not the zinc, it's due to the abnormal effect that it has on copper metabolism, because what happens is zinc and copper get absorbed by the same receptor in the gut. And so if you have too much zinc, it inhibits copper absorption. And it's well described that people with too much zinc get a syndrome that can mimic multiple sclerosis. I'm not going to go through it though, but on the list, when we work up people for MS, we have to do copper and copper levels. So this is just how things work. So that we have to be very, very aware when we see people who present to us with symptoms suggestive of MS to think laterally and not just assume they have MS. And this happens in the Western Isles and probably in Scotland, is that when somebody comes to a neurologist or a doctor and we think they've got symptoms that could be MS, we've always got to step back and say, actually, let's not make the diagnosis of MS. Let's be very, very careful what they've got. And that's very, very important, because I put this example. One of our treatments we use, and I believe, Rachel, how many people are on Tysabri in the Western Isles? 3 people. So there's a treatment, it's a very, very effective treatment. This is a drug called natalizumab, or Tysabri. We give it once a month by an infusion. And essentially, white blood cells that go into the brain use an adhesion molecule. They've got to stick to the blood vessel to pass in. It's like a Velcro. And we give them this drug, which is an antibody, and it blocks these receptors, and the cells don't get across. It's like blocking the Velcro. And it's a very effective therapy. It's one of our most effective therapies. The point about it is if you don't have the cells going into the brain and you get an infection, you can't actually mount an immune response because the cells can't get into the brain to fight the infection. And so people who are on this drug, there's a very high risk of them getting a condition called PML. Anyway, so this particular patient in the trial got this infection and died from this infection. And when she came to the post-mortem, she never had MS. She probably had migraine, right? So this is the consequences of a misdiagnosis. If we put people on these treatments, they have potential life-threatening complications. So this is one of the reasons why we have to be very, very careful about making the diagnosis. So there are a whole lot of flags, and for those of us who work in the field, we have to make sure that we think carefully about making the diagnosis. But that doesn't mean to say people shouldn't be referred in with non-specific symptoms. I would urge you all, if you get people who have neurological symptoms and you have no idea, it's always best to get them worked up rather than ignore them, because there's no doubt the earlier we treat MS, the better the prognosis in the long term.